A very good morning to all. I'll be discussing on determinants of clinical response to empirical antibiotic treatment in patients with cirrhosis and having bacterial and fungal infections. So basically patients with cirrhosis, they have definitely an increased risk of infections which is around 2.6 fold higher than those without cirrhosis, and management of bacterial and fungal infections again is complicated in such patients, mainly because the bacterial ecology in these patients is altered. There is a lot of translocation, appearance of antibiotic resistant genes in such patients. There is emergence of MDR and the XDR, aggressively drug resistant bacteria and fungi that lead to decrease in efficacy of the classical empirical strategies. These MDR infections, as we all know, they present with higher mortality rate, increased duration of hospital stay, and that all leads to the higher healthcare related cost. So when we are going to plan a antimicrobial therapy, we should know what type of therapy are we initiating. When there are no signs of infection but definitely there is presence of risk factors, we initiate the prophylaxis. When there is an ongoing infection but not clinically without any symptoms, but there are presence of biomarkers and laboratory data supportive of that, we start with the preemptive therapy. When there is development of symptoms but again the etiology is not known, we don't have the cultures that are positive, we start with the empiric therapy. And definitive therapy, definitely when we get the cultures positive or a definitive histopathological or other evidence for the pathogen, and then in subsequently in the course of action we start with the suppressive therapies. So this study actually, this is the mainstay of this topic today, the results of the International Club of Ascites Global Study Group, which has been recently published. And this is a multicentric study of 15 institutes from Asia Pacific, 15 from Europe, 11 from South America, and 5 from North America. So this is a huge cohort of patients that they have studied, around 1300 hospitalized patients with cirrhosis across the globe, and ILBS was the lead in this study. So main findings I'll just be showing that this is and Dr. Raki is the lead author in this study as well, so we'll need her inputs definitely about the results. So in this study, alcohol was the most common etiology of cirrhosis, and patients were sick with high MELD and high CTP scores. 31% had indications for SIRS, that is systemic inflammatory response syndrome, and 48% presented with community acquired infections. This is very important that nearly 50% of the patients, they are presenting with community acquired infections. So from day one, when the patient is admitted, the patient is carrying the community acquired bug with him to the hospital, and therefore initiation of appropriate empirical therapy right at the beginning of the admission is very important in such cases. So most common type of infection in this study was the spontaneous bacterial peritonitis, and it was followed by urinary tract infections, and then it was pneumonia. MDR pathogens were observed in 19%, and 5% of them had XDR pathogens as well. Now this is an older cohort. Definitely now the numbers have definitely changed, and MDR and XDR rates have gone much higher than these. The prevalence of MDR and XDR pathogens showed a huge regional variation, with the highest prevalence noted in Asia Pacific region, and definitely I think ILBS must have contributed to nearly more than 50% of these cases. So when they compared the various clinical characteristics of the patients and the response to the antibiotics, so they had two groups, that is clinical response and no clinical response. It was very, the etiology of cirrhosis was not associated with the type of response that the patient received. And however, the other clinical parameters and laboratory parameters clearly showed that increased heart rate, increased respiratory rate, increased WBC count, increased C-reactive protein, creatinine, suggestive of infection or suggestive of deteriorating condition of the patients, were significantly associated with the clinical non-response to the empiric antibiotics. Similarly, ascites, HE, and these patients presented with a high MELD sodium and child score as well. So those patients who presented with grade 3 ACLF, they also had a higher non-clinical response to the empirical therapy, and all the failures like multi-organ failure, including liver failure, coagulation failure, renal failure, there was circulatory failure in the patients who had clinical non-response to the empiric antibiotic therapy. Pneumonia was significantly associated in this group of patients, and Again, community acquired infections were predominant here. So this is very important. That is, most of the times we are focusing only on hospital acquired infections, and the data also for hospital infection control that we are presenting is for the hospital acquired infections presenting after 48 hours of admission. So here the community acquired infections are also very important, that we are dealing in the OPDs or in the wards. The group had mostly the MDR pathogens. Both MDR and XDR bacterial infections and fungal infections were significantly associated with the initial non-response in the patients who received empiric antibiotic therapy. And when there was adherence to the EASL antibiotic treatment recommendations, there was a good clinical response in such patients, which was significantly higher. And empiric antibiotic microbiological efficacy, definitely it was inadequate in the patients who showed no clinical response. That is, whatever strategies or whatever drugs they were using in the patients as empiric treatment, they were inadequate, and there are various studies which show what are the reasons for these inadequacy as well. We'll be coming to that later. So independent predictors of lack of clinical response in these patients, they found that it was the high WBC count, C-reactive protein, hypoalbuminemia, the presence of pneumonia and nosocomial infections as well, grade 3 ACLF, and the antimicrobial therapy, which was non-effective in these patients. What was the outcome when we had such a huge group of patients who were not showing any clinical response to the empiric therapy? Definitely the outcome was poor, that there was development of new infections, development of renal failure, shock, increased hospitalization, transfer to the ICU, mechanical ventilation, renal replacement therapy, increased length of stay in the hospital, in hospital mortality as well as 28-day mortality, all were significantly higher in the clinical non-response group. So these are again the independent predictors of in-hospital and 28-day mortalities, which are more or less similar as previously mentioned. So the key risk factors that are associated with the lack of clinical response, they are mainly associated with the severity of the disease, how is the patient presenting. There are mostly the patient related factors. Then the antibiotic related factors, that is the strategy of antibiotic administration. So for empiric therapy, it is always said that hit hard and hit fast. So we have to choose the appropriate antibiotic. It should be a broad spectrum antibiotic or an antifungal. And again, we have to start it at the right time. That is very important. The initial window that we may be lacking, that has to be covered with the proper antibiotics and antifungals. Again, the host response, there may be various patient response depending upon the underlying disease that he has. Nearly 60% of the patients, however, they respond to empiric antibiotic therapy, and they have a better course of action. And characteristic of the infecting organism, that is the microbe. Now in countries like India, especially Delhi, with a high load of MDR pathogens in the community as well. So there are various studies which have shown that there is high prevalence of MDR and XDR bacterial fungal pathogens in the environment as well, in the community settings as well. So definitely when such patients are coming here, we should expect that they are having MDR infections, and then accordingly the therapy should be initiated. Now the patient related factors also are important when we discuss the empiric therapy, because there are various factors that are altered in cirrhotic patients. There is reduced hepatic blood flow, again higher bioavailability or the serum levels may be seen. Hypoalbuminemia is the predominant reason why the antibiotics may not be working, because again there is reduced protein binding, and then there will be increased serum concentration of the drug, increased free drug will be excreted. Presence of ascites also affects on the elimination half-life. If there is bowel edema, impaired absorption may be there. Reduced cytochrome activity, reduced first-pass metabolism, or the clearance of most of the drugs that we are giving, especially the antifungals. Portal gastropathy, again there is altered drug absorption, impaired renal excretion, there will be increased serum concentrations. If there are shunts like portosystemic shunts, then there will be partial or complete loss of the first pass metabolism. There will be increased bioavailability, and drugs such as macrolides, fluoroquinolones, azoles, they are usually to be used in caution in such patients because of prolongation of the QT interval in such patients. So all these factors usually lead to a clinical non-response in the patients in whom we are giving the empiric therapy. Now it's not always that the whatever empiric therapy we are giving may be appropriate, right? It could be our bugs are different and our drugs are different, right? So that could be there. So this is study which studied the impact of the inappropriate empirical antibiotic treatment on clinical outcomes of urinary tract patients who had E. coli infections. This was a retrospective study. They had a cohort of 701 patients who present with urinary E. coli infections, and 213 of them had received empirical antibiotic treatment. Half of them, that is 103, they had received an inappropriate antibiotic treatment, which they labeled that none of the drugs in the empiric antibiotic treatment regime that we're giving, they were sensitive to the isolate that was subsequently isolated. So, and 110 received the appropriate empirical antibiotic treatment. Here in this study, the mainstay of their therapy was levofloxacin. So what they found in this study, they correlated the various clinical and other parameters, and here they had the clinical admission to medical and surgical ICUs was significantly higher in the patient who had the initial inappropriate empirical antibiotic treatment. Other than that, the most of the pathogens were ESBL producers, and they did not show any response to the drugs that were given as empiric treatment. They had a higher 30 length of stay in these patients. So importantly, the inappropriate antibiotic therapy, because this was UTI that they have studied, not any other bloodstream infection or pneumonia, so the mortality rates were not that affected. But again, here due to UTI also, the length of stay was significantly raised when the inappropriate empirical antibiotic treatment was given. So whenever a patient is coming, we have to assess the patient based on the infection. Assessment of pathogen severity is very important. That is the site and species, the pathogen which is acquired, those which are present locally here. We should be well aware of the local antibiograms that are being shown continuously in the infection control meetings or even in these classrooms. So that is very important to initiate the empiric therapy specifically. Pathogen identification and then initiation of the empirical antimicrobial treatment, presence of clinical and laboratory response, and depending upon that we need to continue or discontinue with the treatment that we are giving. So what should be the therapy? So I'll not be discussing about exactly what treatment we have to give, but again, even the recently published expert consensus on the diagnosis and treatment of end-stage liver disease complicated by infections, these guidelines have shown, have clearly mentioned that a local qualified committee should establish an in-hospital pathogen monitoring system and use this data on the prevalence of pathogens and drug resistance to guide the empirical antimicrobial treatment. So this thing we are doing continuously, that the data is being there, it is being shown. To follow this data is very important, and again this data changes very frequently. Okay, every quarterly there may be a different pathogen which may be predominant in the hospital environment depending upon the patient cohorts or depending upon the external environment, the temperature, the humidity. All the factors are very important. Also the pathogens may be different in the surgical ICU, they may be different in the liver coma ICU. So that has to be carefully monitored. And then coming on to the study has not given in details about the fungal infections. So we studied a bit about the fungal infections, their spectrum and the choice of antifungals, especially for the empiric therapy. So this, we studied around 1600 patients, and it is important that 83% of them were culture negative. So again, this is very important that when 83% of the patients are not showing any positive cultures, maybe because of the ongoing antibiotic therapy or low load of the organism or such pathogens which are not culturable, there are many reasons. So in these cases, empiric therapy becomes the mainstay of treatment now, right? When the cultures are not there, we don't have a definitive diagnosis, so we are going to continue with the empiric therapy in such patients. Positive cultures were seen in 3% of had fungal infections, 13% had bacterial infections, and again nearly 50% were blood culture positive, and others had respiratory and urinary tract infections. Now what are the predictors when we did a multivariate analysis? The important ones that we found were total WBC count, higher total WBC count at baseline, that is admission, hepatic encephalopathy at baseline, and the multi-organ failure that was significantly associated with development of fungal infections subsequently during the hospital stay of this patient. So if we see the WBC count of more than 14.3 into 10 to the power 3 at baseline was significantly associated with the development of invasive fungal infections subsequently during the course of the admission. If the organ failure was less than 2, that is less than 2 organ failure had less likely development of any fungal infections with odds ratio of 1.04. And timing and diagnosis, now usually we have a conception that fungal infections will usually occur later in the later stage of the disease when we are giving antibiotics to the patient, then there will be translocation and there will be increased rate of fungal infections. But however, in this data we have found that nearly more than 90% of the infections were occurring in the first 5 days of admission. So because the cohort of our patient is different, they have hopped multiple hospitals before coming here, and definitely the risk of fungal infections in such patients is very high. And we found that initial first 5 to 8 days there were the maximum number of infections occurring in those duration of time. Role of antifungal therapy, when the antifungal therapy with fluconazole was started on day 1, these patients had a lower 30-day mortality, lower 90-day mortality, and also lower 1-year mortality. However, those who were started on day 4, they had a significantly higher 30-day, 90-day as well as 1-year mortality. So definitely the role of initiation of appropriate therapy at appropriate time is very important. Then coming on to biomarkers, again we studied the biomarkers in a subgroup of these patients, especially bile galactomannan and the serum galactomannan. Here what we found that normally we are taking, during the cohort of these patients which we have considered during that time group, the cutoff was 1 for bile and 0.5 for serum. But however, those who had a cutoff of more than 3.5 had significantly increased chances, that they had a higher sensitivity of around 72%. And for serum, a lower value, lesser than 0.5, that is 0.46, had a better sensitivity in our patient groups. So this is basically that why we need a appropriate empirical antibiotic therapy and how the patient is going to respond to that. So and outcome, basically again, the patients who had fungal infections, their 30-day, 90-day and the mortality at 1 year definitely all were significantly higher who had a positive fungal infections, either by a biomarker study or through the culture. Thus, 68% of the patients with fungal infections in the first 7 days of enrollment, that is within first 7 days of the admission, they died as compared to 47.9 in the control group, and this level was significant, that is 0.002. Thus, a total WBC count of more than 14.3, multi-organ failure, more than 90% of the fungal infections occurring within first 5 days of admission. Antifungals from day 1 may reduce the mortality. We need to study it more, and further studies are definitely needed in this area. Thank you so much.